Good evening, everybody. Welcome to your NIPMED tutorials. Now I'll be taking you on chronic renal failure, also called chronic kidney disease. This tutorial is actually part of the crash course program provided by NIPMED. So I advise you to supplement what you're going to go through with your textbooks, or your lectures from school, or your notes. But it's important that you pay good attention to it so that we can dig in the basic things we need to understand concerning chronic renal failure. Okay, so when we're talking of chronic renal failure, there are three things there: chronic, kidney, and failure. So chronic is a particular time frame. For chronic renal failure, the time frame is usually 3 months. So when the problem has persisted for more than 3 months, now what is the problem? The kidneys is failing, meaning that the kidneys is not able to perform its functions. And in the acute renal failure, the lecture, we went through a series of functions done by the kidneys. So when the kidneys cannot perform its function for a given period of time of 3 months and above, we then say the patient has entered chronic renal failure. And chronic renal failure is irreversible and progressive, meaning that there is nothing you can do to reverse the renal failure once the chronic renal failure has set in. All that can be done is to slow down its progression, or to the extent that you almost halt the progression. All right. So the simple definition I say is that chronic renal disease is defined as a condition of persisting reduction in the renal excretory capacity as a function of the kidney, ability to concentrate urine as a function of the kidney, and conserve electrolytes for at least 3 months. Okay, so we have the time frame here, we have the renal functions here. All right, signs and symptoms of kidney damage are usually not obvious. As with any chronic kidney disease, or as with any chronic disease as a whole, the signs and symptoms of the damage are usually subtle, usually insidious. Gradually, you begin to observe them. They don't blow off immediately like the acute one. All right, so that's a simple definition. Okay, so it usually progresses to a stage that will require renal replacement therapy. Now, current classification. This classification is very, very easy to memorize. The trick I use is that I minus 30. How? So the first stage is there's actually no drop in the glomerular filtration rate. We know the glomerular filtration rate is how we actually objectify the kidney function. There's no drop in glomerular filtration rate, meaning that's greater than 90. But there's a change in the kidney structure. That finding on ultrasound or imaging. So we can see a structural kidney damage, but normal or even an increased glomerular filtration rate like we have in diabetes nephropathy. So let's remove 60. Let's remove 30. So next is 60. So stage 2 of kidney damage with mild drop in GFR. That's from 60 to what? 89. You see where we're going? Now let's remove 30 again. Moderate drop in GFR. That's from 30 to 59. Now let's remove 15, 15. So severe drop in GFR, that's the fourth stage, that's 15 to 29, and then kidney failure or end stage renal disease when it's less than 15. So just remember 30, 30, 30, and 15. You'll be able to memorize the stages of chronic renal failure. So let's talk of the disease causing chronic kidney disease in Nigeria. There are 3 major causes of chronic kidney disease, 3 most common causes. One is chronic glomerulonephritis. Second is hypertensive disease. And third is diabetic nephropathy. These are the 3 most common causes of chronic kidney disease in Nigeria. So, chronic glomerulonephritis. This is when there's a chronic inflammation of the glomerulus. Okay, so there's an inflammation of the glomerulus that has been ongoing for greater than 3 months. It's called chronic glomerulonephritis. And the glomerulonephritis could be caused by different reasons. It could be the one from rapidly progressive glomerulonephritis. It could be the one from membranous proliferative glomerulonephritis. There are a lot. Glomerular diseases can actually be differentiated into 2 groups: those causing nephritic syndrome and those causing nephrotic syndrome. Remember, nephritic syndrome is the one that has hypertension, oliguria, mild proteinuria, and hematuria. While nephrotic syndrome is one that has massive proteinuria, greater than 3.5 grams in 24 hours loss of protein. And we have, because of the protein is losing, we have some form of drop in oncotic pressure leading to peripheral edema. So there's also edema. Now the body has lost a lot of protein. The liver tries to compensate and then starts producing excessive triglycerides. So we have hypertriglyceridemia. So there's hyperlipidemia proteinuria, which is massive proteinuria, peripheral edema. These are the pointers to nephrotic syndrome. So glomerular disease, you think of like that, those causing nephritic syndrome, those causing nephrotic syndrome. Then we have some that cause both nephritic and both nephrotic syndrome. Okay. Next is hypertensive diseases. Now, hypertension itself could be primary essential hypertension, which is the most common, which also causes kidney damage. Second is the renovascular occlusive one, the one that occurs in renal artery stenosis, the one that occurs in fibromuscular dysplasia of the kidney vessels. Okay, these are two common causes of chronic kidney disease. So, hypertension, why? Hypertension is when there's a persistent elevation in the blood pressure. If the blood pressure is persistently elevated and it's not well controlled, there's going to start being damage to the blood vessels, particularly blood vessels in certain organs, the kidney, the brain, the heart, the retina. So if the kidney blood vessels are involved, there will be fibrinoid necrosis. Fibrinoid necrosis is a form of necrosis in which fibrin exudates deposited. So fibrinoid necrosis of the vessels involved in the kidney, which are the afferent arterioles. So when these vessels are damaged, there's going to be some form of, to lead to a decreased renal filtration, then leads to scarring of the renal parenchyma involving the glomerulus and the interstitium. Okay. Now, diabetic nephropathy. Now, this is very interesting. Diabetic nephropathy. In diabetes, we have a lot of sugar in the blood, right? So normally these sugars don't bind to proteins anyhow with their normal physiological concentration. But when we have an excess amount of sugar, what happens? Even without the presence of enzymes, these sugars begin to bind to a lot of proteins, and this is called non-enzymatic glycosylation. Okay, now let's think for a minute. Now, imagine this sugar goes and starts binding to proteins that are involved in the glomerulus, such as the proteins of the basement membrane. So we start having non-enzymatic glycosylation of what? Basement membrane proteins. Imagine these products of non-enzymatic glycosylation goes and affects the efferent and the afferent arterioles. Okay, so when they go to the arterioles, we have the efferent, those taking blood from the kidneys, and the afferent, those bringing blood towards the glomerulus. So initially, it's actually the efferent arterioles that first undergo it. So when the efferent arterioles undergo this non-enzymatic glycosylation, they form hyaline arteriolosclerosis. Okay, so there's hyaline arteriolosclerosis of the efferent arterioles. What happens? So the efferent arterioles have been narrowed. So we're going to have an increase in the what? Glomerular filtration rate, hyperfiltration. Now this hyperfiltration is going to cause the glomerulus to undergo hypertrophy, and also they're going to begin to do what? Undergo scarring. That's one. Now, secondly, there's a lot of glucose in the blood. Now, the body has what they call aldose reductase, which converts glucose to sorbitol. What does sorbitol do? Sorbitol goes to different organs. Now, organs that have sorbitol dehydrogenase, such as the liver, the ovary, the organs of the seminal vesicles, they can be damaged by excessive sugar because they convert sorbitol to fructose. But organs like the retina, organs like the kidneys, organs like the eye, the anterior chamber of the eye, these organs, they lack sorbitol dehydrogenase, so they are prone to, and also the nerves, the neurons, so they are prone to the osmotic damage caused by sorbitol. So the glomerulus and basement membrane also undergo osmotic damage because of this. Now the hyperfiltration together with the non-enzymatic glycosylation end products are going to affect the mesangium in the kidneys. They're going to do what? Make the mesangium to what? Expand. Okay. Now this expansion of the mesangium will give the mesangium a certain appearance, a certain change, and it's called Kymester-Wilson's lesion. And Kymester-Wilson's lesion are pattern mnemonic for diabetic nephropathy. So we have mesangial damage, we have basement membrane damage, we have glomerular scarring, all this, and we have hyaline atherosclerosis of the efferent arterioles initially, leading to a rise in the GFR, but later the afferent arterioles are also involved, leading to a drop in GFR. So all these factors taken into account will then lead to diabetic nephropathy. Okay. So we also have interstitial nephritis, which is caused by which should be caused by analgesics, which is caused by drugs. Analgesics that are mostly involved are the non-steroidal anti-inflammatory drugs. They know that they cause acute interstitial nephritis, which is a form of autoimmune disease. But if this acute cause isn't corrected, it could then progress to a chronic interstitial nephritis. Obstructive uropathy caused by BPH, bladder cancer, bladder tumors, even blood cancer obstructing the ureter, any form of issues that will obstruct the outflow tract of the kidney. Remember, if the outflow tract of the kidney is obstructed, the pressure ascends and it goes to the ureter, it goes to the renal pelvis before it enters the kidney. So the kidney, usually you might see some form of hydronephrosis, dilatation of the kidney and its outflow tract because of the obstruction. But later, at the level of the glomerular, there's going to be an increase in pressure in the Bowman's capsule. When the pressure in the Bowman's capsule increases, the pressure gradients within the capillaries and the interstitium drops. So there's going to be a drop in glomerular filtration. Other causes like polycystic kidney disease, HIV-associated nephropathy, sickle cell nephropathy. There are a lot of causes of chronic kidney disease. Now, if a patient comes to you and you're managing the patient for chronic kidney disease, there are certain things you have to take into account that will help you in monitoring the progress of your patient. All right, and these are risk factors that you try to modify, you try to prevent them from causing more problems. Like we know in medicine, risk factors are always divided into two groups. We have the modifiable risk factors and the non-modifiable risk factors. So for the non-modifiable, we usually have things like genetics, sex, age. You can't make somebody younger. You can't change somebody's gene. You can't make a man a woman. All right. So the modifiable one, we have hypertension, diabetes mellitus, hyperlipidemia, obesity, abdominal circumference. All these are part of the hyperlipidemia and obesity. Smoking. So you want to make sure that these lifestyle modifications are adhered to. You want to take hypertension. Usually a target of less than 135/80 of the blood pressure should be your target. You want to control the sugar level. You want to prevent hyperlipidemia. You want to encourage the patient to lose weight. You want to also advise the patient to stop smoking. Those are the things that you want to take into account when you're monitoring the patient who has chronic kidney disease, as this will help in reducing the progression of the condition. Next, we have the clinical features of chronic renal failure. It's a chronic kidney disease. It's a chronic disease, so these features are going to occur insidiously. All right. How do we memorize these features? Let us go back and think about what the kidney does. It excretes waste. Most of these wastes are nitrogenous waste products. So we're going to have things like anorexia, nausea, vomiting, hiccups, diarrhea. Because when urea accumulates, urea causes all those problems. Okay, urea goes to the stomach, causes uremic gastritis that causes nausea, vomiting, and some form of epigastric tenderness. It could also cause diarrhea when it has involved the small intestines. Usually anorexia in the form of loss of appetite. If uremia goes to the brain, causes uremic encephalopathy. We see something like asterexis, which is flapping tremor. We see twitches, confusedness, convulsions. Urea could also go to the heart, to the pericardium, and cause uremic pericarditis. So people complain of some form of pain that gets worse with inspiration. You see like that, uremic pericarditis. And then when you listen to the heart, you might hear some form of distant heart sound or some form of pericardial friction rub, particular sound called pericardial friction rub. You get in patients that have pericarditis. Another thing you'll notice is that the kidney is where calcium is reabsorbed at the level of the distal convoluted tubules and also at the level of loop of Henle. But at the level of the proximal convoluted tubules, it's where calcium, vitamin D3, which is needed for the reabsorption of calcium and the formation of osteoid in the bone, is converted to its active form. So vitamin D has to be converted to calcitriol, and that last process occurs in the kidney. So taking into account that the kidneys cannot reabsorb calcium, that the kidneys cannot activate vitamin D3, there's going to be general hypocalcemia. What does that do? This hypocalcemia is going to trigger the parathyroid hormone. Parathyroid hormone is not going to be produced in large quantities by the parathyroid gland, which is then going to activate osteoclasts in the bone. Osteoclasts are going to begin to resorb bone, breaking the bone down. And when that occurs, there's going to be increased risk of osteoporosis, and this is called renal osteodystrophy. All right, good. Also, remember the kidney produces erythropoietin. So when there is kidney damage, when there's kidney failure, the kidney cannot produce erythropoietin. We're going to have what? Anemia. When the urea concentration in the blood increases, urea will actually affect platelet function. So we're going to see some form of what? Platelet dysfunction in someone that has chronic renal failure. Okay. Now we're going to have severe hypertension, very, very severe, because the kidney is the organ that excretes fluid. So when the kidneys are shut down, there's going to be impairment to fluid excretion, which is going to do what? Lead to severe hypertension. Or we have congestive cardiac failure. So we have severe hypertension, we have fluid retention. The heart's going to have more work to do because the heart has to pump against a higher afterload. Person develops congestive cardiac failure. And then symptoms get worse. So some lab findings going to see elevated urea and creatinine. Creatinine is the marker of kidney function. Okay, especially of the glomerulus, because creatinine is only secreted, it's only filtered. It's a very, very minor secretion, of course. So creatinine is mostly excreted by filtration, as opposed to urea. Urea is filtered, is also reabsorbed, and is also secreted. Okay, so creatinine is the most important marker of renal failure or acute renal failure. So we have urea, we have creatinine, we have phosphate, uric acid, they all go up. We have calcium that comes down. Usually sodium concentration does not change, and potassium usually rises because the kidney excretes potassium. So when there is an impairment in kidney function, drop in GFR, potassium levels are going to accumulate. So it's going to be hyperkalemia, which is deadly, and you have to take note of that and monitor the patient's electrolytes, particularly the potassium, as often as you can. Yeah. We just spoke about this. So these are specific markers for chronic kidney disease. One that's important here is, and are very, very basic, at albumins. Albumins are going to drop because the kidneys, the glomerulus are damaged. There's going to be a lot of protein loss from the glomerulus. We're going to see hypoalbuminemia. Since protein is losing via the glomerulus, they're going to be excreted in urine. We'll see proteinuria. And the patient might tell you that they have frothy, foamy urine. Okay. Another thing that is common in chronic kidney disease, because of the edema that occurs, usually the edema begins periorbitally and is mostly seen when the patient wakes up. So we're taking your history, you have asked the patient, do you have swelling that occurs in your eyes? The patient will be like, yes, mostly in the morning I have that. Because as the patient wakes up from there, he has swelling in the eyes, mostly in the morning. As the day passes, because of gravity, the swellings actually come down. So radiological investigation, plain abdominal X-ray is going to help us find some stones if they are there, especially if they are radiopaque stones. Renal ultrasound. Renal ultrasound is very, very important. It shows us the structures of the kidneys. And in chronic kidney disease, we mostly see shrunken kidneys and loss of cortical medullary differentiation. But in diabetic nephropathy or amyloidosis, we don't see shrunken kidneys. We actually see normal sized kidneys or even enlarged kidneys. Okay. High dose IVU shows obstruction. CT scanning help us also. So one of the most important things as a doctor is, in addition to making a diagnosis, one of the things you want to do is you want to assess the cause. You just want to know the extent of the damage, how bad has the damage occurred. You want to know, okay, since this is the extent of the damage, how good does this kidney still function? And then which other disease does this patient have that we can tackle to prevent the progression of this particular failure? Okay, so those are important things you want to assess. You want to also assess if there are complications, such as renal osteodystrophy, like we said, uremic gastritis, uremic encephalopathy, coagulation defects. Okay, those are some important things you want to make sure are not there. Anemia also. So management of every disease is divided into two groups. We have the pharmacological management and the non-pharmacological management that involves lifestyle modifications and so on and so forth. So you want to adjust the diet. You should take in less protein, less phosphorus, reduce sodium content, because sodium also contributes to fluid retention. And you want to increase the amount of carbohydrates he's taking. Why? Why? Now, if the patient is diabetic, you want to be careful so that you don't tilt the person towards having worsening the person's blood sugar. Okay, so you don't want to actually give excessive carbohydrates, but Proteins are also a source of calories because proteins can be broken down to provide energy. Okay, now the kidney, 30% of the body's gluconeogenesis occurs in the kidney. So if people have kidney failure, they are prone to having hypoglycemia. Secondly, the enzyme insulinase that breaks down insulin or that inactivates insulin is also produced by the kidneys. So when somebody has a chronic renal failure, they start having a secondary hyperinsulinemia. So in patients that have diabetes now, you want to start reducing the dose of the hypoglycemic agents you are giving or the anti-diabetic drugs. Sometimes if you don't even give them glucose lowering drugs and you see that their glucose levels are still fine. That's why I wrote increase in calories in diets. All right. So in addition to preventing the complications and treating the complications if they arise, and also if you are managing the lifestyle modifications to prevent their progression, if it still progresses and we have a glomerular filtration rate of less than 15 mils per hour, you then want to go to renal replacement therapy, which is usually with dialysis or with renal transplant. I'm sure you know the indications of dialysis, things like metabolic acidosis, bicarbonate less than 13, or pulmonary edema when the chest are congested from fluids because of fluid retention, or hyperkalemia, potassium greater than 6.5, which is actually very, very deadly. You want to correct that. Okay, and if there's any clinical evidence of uremia, uremic gastritis, uremic encephalopathy, these are very, very life-threatening conditions, and you want to also take care of that. All right. This concludes the lecture on renal replacement therapy. I'll see you next time.